I got so excited working with Heidi on this event because she is really the type of sales expert that I wanted to learn from about how to get inside of hospitals. I have tried to market to hospitals for years in my career, and it is a tough thing. And I think Heidi's expertise and experience really is going to pay off for all of us. So I am just super excited about that. And thank you so much, Heidi. Take it away.
Sure, thanks. And, so hey, I see a lot of folks out there. I see Denver, I see Nashville, I see Florida, Illinois. I am in Albuquerque, New Mexico, and it is a fantastically beautiful day here. So thank you. Good afternoon or good morning, and welcome to Selling to Healthcare Organizations. As David said, my name's Heidi Munson, and I lead the partnerships, EHR partnerships here at Redox. Over the last 20 years, just a little bit about me, and David, thank you for that really nice introduction. I've been in healthcare sales, leadership, sales training, and sales strategy for about the last 20 years, where the first 15 or so of those years, I spent in a multi-billion-dollar company designing and leading both sales and customer success organizations. Now, a few years back, I left that safety net of that mammoth company, and much like many of you on this call, I joined the world of the healthcare startup. I was employee number 10 and actually the first real sales guy there for a disruptive telemedicine solution. Our solution allowed for diabetic eye disease to be diagnosed in primary care rather than in ophthalmology. So very disruptive. And as a typical startup environment, and you guys probably know what I'm talking about, but depending on the day, I was sales operations, I was sales, I was project manager, marketing, customer experience. Didn't matter. So I got some great experience, and then I got the ability and the opportunity to come over and join Redox a few months ago. And my job is to ensure that, at Redox as part of the EHR partnership team, that your customers' experiences are high quality no matter what EHRs they're using on. So today's focus, therefore, for you is going to be on your customer and improving their overall experience within your sales cycle. So I hope that's what you guys came to learn. And hey to Canada, glad to see an international presence. I'm going to be sharing with you today perhaps a new angle on how to manage your healthcare sales funnel. This is an approach where we look at each opportunity from a 360-degree view. Your internal sales planning, tools and cycles, what your competitors might be up to, and then what I believe to be the most important part is the healthcare systems themselves have an internal decision cycle. So my hope for you today is that you find at least one new idea or tool that you can incorporate into your sales and business planning. Whether you came here to find sales acceleration ideas, to learn to better shape your deals, or you want to win more sustainable deals, that is the focus of having really a healthcare-centric selling strategy. We're going to start with a connect to purpose. I'd like to always remember that the stakeholders within a healthcare system, first and foremost, are there for their patients. Next, we're going to look at healthcare trends, what has become the quadruple aim within a healthcare. And we're going to use this as a model to find and align the value of your own solution within your healthcare system targets and priorities. After talking through how you define your fit, we're going to move into strategic planning sessions on how to identify individual opportunities and create what I call political influencing maps of your stakeholders. So now we're here, we have an opportunity and a sales plan, and we're ready to look at how to fit our sales opportunity into the decision cycle within the healthcare organization. Then we align our sales activities to help the organization advance more quickly through their internal cycles. Finally, and David mentioned, he's got a site for you to download. We want to be able to give you actionable tools that you can incorporate into your internal processes and conversations. So we're going to share a strategic opportunity plan that can help you and your sales teams execute what we've talked through today. So that being said, let's dive in. As I mentioned at the beginning, I'd like to take a moment and connect to purpose. So first, if you have joined today's event, you likely have a technology, a service, or a product that can solve a really big problem in healthcare. So on behalf of Redox, I want to thank you for joining, and I want to thank you for the work and the contributions you're making to improve the overall healthcare experience. So we've seen the state of healthcare today. There's stress, there's fear, there's fatigue. That is more real and more tangible than ever before. But let's just try for a moment to set that aside and understand that the day in the life of the folks within the healthcare organization and the reality even before COVID. On a good day, healthcare is short-staffed, teams are overworked, new priorities pop up every day. On a good day, healthcare leadership is tasked with reducing costs, charged to increase access, and mandated to improve outcomes. All of this while trying to keep their clinical teams from burnout. So this, what you're looking at, is a structure of a healthcare system. The leaders at the top make the choices that the users on the front lines at the bottom need to implement. This is our reality. They may be solving problems on a national level, or they may be dealing with geographic issues where, like, patient demographics create unique healthcare challenges. We might have a product or a service or a technology that might help solve this problem, right? So let's take the problem of reducing no-shows in healthcare. This is a really big, really costly problem for those of you who don't know. Now, if we look at no-shows in urban inner city areas, access issues may be due to maybe the availability of public transportation, bus schedules, or traffic. Workers might have trouble scheduling time off for appointments, or maybe even have to make financial choices around healthcare. So no-show rates could be high as a result of this. Now, in rural areas, on the flip side, they have no-shows, but there are really different reasons there. Access might be around physician availability or physician shortages. Finding comprehensive ophthalmology or oncology could mean struggling to find an appointment and then still having to drive for several hours to get there. Both of these access issues are real, they're important, and they cause a domino effect of managing a practice. But how does a healthcare system prioritize solving these issues? And can one technology solve for both problems, or do the root causes require them to look for different solutions? So regardless of whatever technology gets implemented, the frontline workers have pains and needs that go well beyond that single problem. So how do we, as their service or product providers, help to get our solutions prioritized still above everybody else's? How do we win mind share in our most strategic healthcare organizations when everyone else in the space can solve a different, albeit very real and important pain? Every area of healthcare benefits from technology, but is improving provider efficiency really more important than the patient experience? What about quality metrics? They show healthcare system performance, but do decisions around conservative corporate integrity and compliance make decision-making more challenging? The simple need to remind patients they need to refill prescriptions or get annual wellness visits create financial, clinical, and operational burdens that directly fall onto the frontline workers and up their chains of command. So healthcare systems are limited in human capital, in time, and in expenses. So how do we earn the right to ask for any of their precious resources? Now, in daily work, and especially in today's COVID environment, empathy is critical, but it's also sometimes an undervalued trait. Understanding this environment as you approach your healthcare systems can and will help you better shape sales conversations and your sales activities. Meet your stakeholders where they are in their decision cycle, and we'll talk about that today. And you guide them through their purchasing decisions by giving information relevant to where they are, not where you want them to be. Learn about their organization, learn about their behaviors, their internal processes, and then align your activities to make their ability to decide on you as their choice a whole lot easier. So let's take a look at the trends in healthcare so you can start thinking about where you fit into all of this mess, right? High-performing health systems operate on the framework of a triple aim: quality of care, access to care, and cost of care. Within the last couple of years, some have even started including clinician experience as well to make it a quadruple aim. As vendors, it's critical to understand that this balance is core to how healthcare decisions are made. Healthcare organizations work to reduce costs, increase access, and improve quality of care in managing total patient populations. This framework, the triple aim, it emerged around 2007, 2008, and it's been a contributing factor to the evolution of what we now know as value-based healthcare and quality metrics in place today in 2020. So health systems and their providers have been transitioning from this traditional fee-for-service model where they were reimbursed almost by line item for treatment over to what's now known as quality-based models, where improving overall outcomes of high risk and other populations should eventually shift to a healthcare model where prevention controls strategic clinical and financial outcomes. So the macro trends supporting the triple aim They are going to include interoperability, value-based care, transition of moving primarily from that inpatient over to patient-centered medical home and outpatient. I read recently an article from Deloitte where they analyzed current trends within the triple aim where interoperability is a critical need. Now, I'm going to give you a hint. Sarah, a little later today, is going to talk about how physicians identify interoperability as that really important problem, but it feels to them like an unsolvable pain. So make sure you stay tuned for her session. What I want to focus on is just quality, right? Quality, we all hear it. Our clinics hear it, our practices hear it, and there are value-based models in place now rewarding that quality rather than compensating like they used to for quantity. Quality programs are designed to drive clinical behaviors previously influenced by that fee-for-service payment structure. The last decade, we've seen things like PQRS, which is physician quality reporting systems, and meaningful use, if you're familiar with that, rise up, only to transition now the best of both of those worlds over something called MACRA and MIPS. If you're not familiar with MACRA and MIPS, these are new payment models that were put in place, continuing to advance that process of rewarding for value over volume. I'm going to give you a little homework there, headache and homework. Go out and research MACRA and MIPS. If you don't know and understand this, learn about it. It's an important conversation happening in healthcare right now. So the healthcare organizations also, they've got that homework and they've got to go out and try to understand these confusing changes. So the better versed you are on them, the better conversations you're going to have with your clients. We're going to talk more about quality measures in the next few minutes, but I'd love for you guys to start thinking about where does my app fit within the quadruple aim? This is a really important exercise in aligning the right value prop to your healthcare system and, more importantly, to your champion's needs. So, improving quality of care is now measurable. It's tangible. CMS puts measures in place that hold health plans accountable to compensating for quality over quantity. Your payers like Cigna and United, they have several different approaches to hitting their quality goals, as is measured by something called star ratings. They then use these payment models to pay their physicians or their providers, which might include something called risk sharing or shared savings, and many other things. So I want to take a moment real quick and have a sidebar conversation around nomenclature. Stars ratings and stars performance. This is a differentiation that as a vendor, if you know and can speak to it, is going to give you a little bit of street cred. So health plans are measured by star ratings. The providers and the healthcare organizations are not measured by star ratings. They have star performance, where they are required to report their performance to the health plan. The performance across the health plans, all of the health plans providers, is what CMS then uses to give the health plan their star ratings on 1 through 5, 5 obviously being best. So that's a little bit of street cred. These star ratings are public as well, and that's, David's going to be providing some of those tools on how to go out and find how the health plans are rated, maybe within your area of prevention or diagnostic or consumer satisfaction. So another brief aside I want to talk through is risk, because I mentioned some risk sharing in some of the payment models. For those of you who aren't familiar, risk in this context is very different than risk management in healthcare, where they're working to reduce slips and falls, things along that line. Risk management is reducing the risk to the health system through effectively managing internal processes and procedures. Risk, as a financial model, represents the onus of the financial burden relative to care delivery. Okay, the level of risk is then shared across 3 entities, and it takes shape by way of the payer contracts, right? The healthcare plan, health insurance. The entities are the payer, its contracted providers, and it's what they call its members or our patients under their care. As quality programs continue to develop, we see more and more healthcare organizations and providers take on greater financial shares of that risk, that burden. So for owning the risk, they are then able to share in the savings or incentives that the health plans earn for better management of their populations. Okay. Now, when we talk enough on risk, let's talk about improving quality of care relative to the costs and reducing costs of care and improving the overall profitability. There is definitely financial gain as well as financial loss that results from hitting quality metrics. Whether you are a health system trying to improve your HEDIS scores or increase star performance, or focus on building out your patient-centered medical home certifications through NCQA, typically a health system and its providers would be financially incentivized from metrics attainment. This is why understanding if your solution helps to improve a measurable quality goal of the health system, and to learn from your health system if that particular quality measure is even on their radar. Let me give you an example. When I started with my former company back in early 2015, the diabetic eye exam was a HEDIS measure, but HEDIS hadn't really gained its strength as it has now. So I met with a very large ACO group in Ohio that said, well, sure, HEDIS, but it isn't an ACO measure. I've got 23 ACO measures I have to focus on. Conversation stopped. Now, a couple of years later, the diabetic eye exam became an ACO measure. So now they have to focus on it. Imagine that. It's a great thing for my former company. Quality measures like that diabetic eye exam are concrete, but the health systems determine the relevance and level of focus by many influencing factors on which measures they're gonna go after. Study up, more homework for you, study up on quality in your area of expertise if you aren't already familiar with it. And then don't be afraid to step into those conversations. If you're still learning about it and you have champions in health systems that you know well, ask how you fit into their quality goals, and they're really usually very happy to share that information with you. So let's move on to reducing costs of care a little bit more. Doing things more efficiently and saving money is a really important focus of the triple and quadruple aim. We've spoken already about value-based payments like MACRA and MIP. Remember, that's your homework and your headache from earlier. Let's talk about HCC RAF, or what's known as risk adjustment models and risk adjustment factors. In a little bit, we're going to go through a sales journey trying to shape an opportunity for it's a made-up diabetic foot exam via telemedicine. Sure, telemedicine has a lot of cost savings around efficiency, but the outcome of the exam may actually have financial implications. HCC RAF, risk adjustment factors, they're assigned to what's known as eligible beneficiaries. These eligible beneficiaries are really the at-risk health plan members or the patients who have some kind of morbidity or comorbidities. Remember, we just talked about risk, right? So let's say the health plan has a population of 1,000, 2,000 members, just for round numbers, spread across 4 provider groups. The plan pays the provider, and I'm going to use round numbers here, and you don't have to take notes. The plan pays the provider maybe $750 per member per month. This is known as PMPM. Okay, maybe you want to write that down. Per member per month to provide care in a shared risk model. So now let's say I'm a provider and I've managed 500 lives within that payer contract. That represents about a $375,000 a month contract value for me to manage those lives. Now, I also treat a subpopulation within that panel of 200 patients with diabetes. This means I get a risk adjustment factor, a RAF multiplier. Let's pretend, I'm throwing out kind of round numbers here. Let's say it's a 0.25 increase to my PMPM, per member per month, for my 200 members with diabetes. That's roughly an additional $37,500 in PMPM a month. Now let's say that I contract with a visiting nurses association to provide care to some of those members who also have mobility issues. That nurse uses your program, the diabetic foot exam telemedicine product, and finds neuropathy in 25 members. Now, as those members' provider, their health plan recognizes another complication and increased risk coded to the highest level of severity, and I'm going to come back to that. That adds another multiplier to the PMPM. So let's pretend that diabetic foot complication is a 0.4 multiplier, giving me an additional $9,300 per month. I'm now getting paid more to care for my most at-risk population. Meanwhile, I'm finding effective tools to improve overall outcomes. My $375,000 per month contract value has now increased by $45,000 per month more to $421,000. I mean, heck, that is a lot of money to a practice, and they can calculate an ROI on using our product. Now we see how improving quality while decreasing costs starts to snowball into improved outcomes. Now, I mentioned coding to the highest level of severity as part of RAF. And this might be a function that you can provide within an integration. So let's say that you do have a diagnostic product like this diabetic foot exam. And within the diagnostic product, you have the ability to return discrete structured diagnostic data coded to the highest level of severity. That's a huge selling point to a health system. That's something you and your sales team need to know about. Now, Redox, as your integration partner, we can help you integrate, but your team needs to have the product expertise around your capabilities. So if this is a feature that's relevant in your world, bring it into your sales strategy. And just remember, though, that relevance. Sarah and Paige are going to talk a little bit later about the importance of the technical sales conversations that you're having early on. So this is just a really good example of it. Remember the terms in coding to the highest level of severity. It is really important across all of healthcare for many reasons right now. All right, we're going to move on to the third in the triple aim, which is improving access. We see this happening in real time as we watch the VA work to increase access to care. Okay. Too few appointments available. There's a shortage of physicians, inefficient processes such as double or triple booking provider schedules. There's bureaucracy and archaic technologies. This list goes on and on and on, right? But this issue of access isn't isolated to only our precious veterans. They are some of our most vulnerable, our most vocal, and our most visible. But this problem exists across geographies, across demographics, socioeconomics. If you have a solution that improves access, such as virtual appointments or remote patient monitoring, learn your talking points. Get with your marketing team or your marketing guru and fine tune that messaging. This is really, really important. Now, finally, I mentioned the fourth pillar in the triple and now quadruple aim is improving the clinician experience. This might mean you can reduce redundant documentation or maybe improve their clinical workflows. These heroes will become your champions if you can lift just a little bit of stress or pain from the day in their life. The trends that we're talking about and visiting, these are national trends that healthcare organizations use to make decisions. It's a framework for you to align your value propositions to your target organizations. And you might think, well, hey, Heidi, I cross across all areas of the triple and quadruple aim. I would expect you might. Each trend has its own value prop, and depending on where you are or who you're speaking to, that value prop has its own unique spin. So an example, if you're talking to a physician about quality metrics, you want to talk to him about how it's improving the overall patient outcomes. But if you're talking to an executive like a CFO, that quality discussion shifts and it becomes around the quality incentives and the ROI. Learn these differences and be prepared to shift your messaging ever so slightly to your stakeholders' why, not to your own. So that was a lot of information. We have an understanding of value props aligned against the quadruple aim. Let's take that information and let's start shaping an opportunity. Earlier, I promised that we would look at a sales journey from finding our trends to shaping the opportunity and planning to win your deals. Our imaginary app, we're going to call it Telepodiatry Solutions. I know that telepodiatry is something that was being researched back in December of 2019, and to my knowledge, there's not an existing product. That's why I'm picking on it. But also realize, get a little bit of benefit of the doubt here. Some of this is imaginary research just to show you how to go ahead and do this. So my product, I have a telemedicine solution for diagnosing diabetic foot disease during a home visit from a registered nurse. My solution prompts the nurse of patient eligibility within the EHR. She uses photography along with physical examination to get the information to the primary care provider. He's then able to diagnose based on notes and media, thereby having the complication added to the patient's problem list in the EHR. Sounds cool, right? So now I have my product. My marketing team needs to do a little bit of research. Where does my product fit into the triple or quadruple aim? And what are my talking points? From a quality perspective, we've identified the foot exam as a HEDIS and an ACO measure as part of the diabetic bundle. However, from a STARS measure, the foot exam is not part of the STARS rating system. I know I can talk about not only how my solution can enable a visiting provider to complete an exam, but I can send back CPT codes for reimbursement, and I can send back CPT-2 codes for quality reporting to show the exam was completed. I can also return any applicable DX codes for that RAF implication that we talked about, right? So this is all great news. But wait a minute. So I'm going to show you guys in a few minutes a real world of example of not recognizing what or who we didn't know. But let's look at my research needs column here. Under my areas of access, I know there's a CPT code for the diabetic foot exam, and I know that 2028F is the CPT-2 code that closes the measure. What I don't know is if these codes can be dropped from a home health visit rather than a physician visit. This is research I need to complete. This doesn't mean my app is dead in the water. Instead, it means I need to align my value prop around my benefits, the quality, the HCC RAF, access improvement, all of those things, and not speak about reimbursement until I understand the impact. So another note, a little bit of education for you guys. When we talk about quality attainment versus billing and reimbursement, they are two totally separate functions. Just because something closes a care gap, right? So my diabetic foot exam, performing that exam closes the care gap does not mean that the health plan is willing to reimburse in a fee-for-service environment. My customer might get credit for closing that care gap by doing that foot exam, but they maybe need to make a decision to absorb the cost of the diagnostic in the home care environment as not reimbursable. So I get that this sounds like it could be a really scary conversation, but these are conversations that your marketing team knows how to message. And these are very realistic business conversations that happen every day in healthcare systems. They've been making these decisions for years. They're made around clinical considerations, financial considerations, and operational impact. Everything has an ROI, and it is really important to know yours and how to message it and how to be transparent about it. Okay, so now I am researched and I am prepped and I am ready to engage my healthcare organization. Now, I may know a guy. He's a regional medical director at a health system in Kentucky. While he is not the decision maker, he has major influence. So my champion treats a large panel of patients with diabetes, and he struggles to monitor and diagnose for foot disease. He and his colleagues have issues with patient compliance to their care plans. So at times, foot disease goes unnoticed until it begins to advance. He's vested in finding a solution to increase access and improve quality and outcomes. So I've done my research. I know from a quality perspective that this particular organization, and I'm going to call them out because I've researched this one and they're incredible. St. Elizabeth Physicians in Kentucky is a really high performing organization in quality among its peers. It has high scores in HEDIS measures, but they're always looking to continue to raise that bar, and ACO measures are based on a bar. So I'm going to work with my champion, not to present him my product, but to start figuring out who is part of a decision team within my target healthcare system and how to best align my value propositions to that team. I've already gained his buy-in and he wants me to succeed, so helping me helps him. I know that my big value may be an HCC RAF, and I know there's also quality incentives. I'm not necessarily sure of the ROI around either, but I know enough to know that there are financial gains that make my solution budget positive. From an access standpoint, I know rural Kentucky has issues with geography, and I also know that this particular geography has a high prevalence of diabetes, so the region in general may look favorably on diabetic solutions. Now, should my guy also want to introduce me to his buddy who oversees technical and medical informatics? I'm ready for that conversation as well with returning to discrete structured data. So we're ready to go. One thing I am going to remember every time I'm talking with my champion, I'm going to have a pen and paper and I'm going to take notes specifically about a political map that I'm going to build to start helping me navigate my opportunity. And that is a tool that I came to love very early on in my career. It's the org chart, because I could see relationships and stakeholders within any organization. And then when LinkedIn came along, and yes, I am old enough to remember pre-LinkedIn. So when LinkedIn came along, creating my own org charts got to be a little easier. And with transparency in healthcare today, finding org structures isn't really daunting anymore. So what does that mean? What does that look like? This org chart is representative of a ministry market healthcare organization. That's a type of structure, ministry market. You see the National Health System executive level up there at the top with Joe Martin. The regional ministry reports up through the national, and then the medical group is a function within the ministry that handles ambulatory care, and those are your three layers. I'll go into the structure of an organization and how it impacts decision-making shortly, but I'd like to take you through my real-world example, pulling together what we've learned to this point. We've learned to figure out how and if we fit into a quadruple aim, and then to ensure that we can speak to our value across these aims and across our stakeholders. With the proper planning up front, we can start to create a snapshot of our opportunity and begin working with our champion to figure out who and how to position within his or her organization. So the next step in the process is to figure out who in the organization might even care. Working through our own research, maybe information in Salesforce or another CRM, and hopefully with insider information from your champion or your coach, you could start to lay out a visual map of the organization. So I made this one just using a SmartArt graphic in PowerPoint. It's a real structure of a national health system, and my goal was to sell one of their ministries. You can see I had very strong relationships across the medical group within the ministry, which is exactly where I needed to be. And when I start color coding my org chart, I start to see other areas of influence, right? So my green, my champions, my coaches, these are people who I know really well and who I know support my product. Then there's blue. These are people who I consider to be additional opportunities. I know them, but maybe not as well as I would like to. So I might ask my champions to help me here in deepening those connections. Gray, a little foggier, it's a relationship target. I really don't know them at all. But maybe if I meet them, I might find they have a degree of influence. I might not spend too much time here, but certainly I wouldn't shy away from a meeting if offered, right? Red, our barriers. Speaks for itself. We'll come back to them. So here's what happened. We were heavily ingrained in great conversations and advancing our opportunity, and we had operational and clinical connections. No red flags were going off within the medical group. Truth be told, we knew Shelly, the IS director, really didn't want to bring in another integration project, and that's not uncommon of IT. But David, we needed, he was in our corner. At the ministry level, the chief nursing officer was in our corner, and she absolutely loved the workflow our product could bring. Now, this is important. She was also accountable. She owned quality measures, and she had full confidence in Melinda Marshall's recommendation to proceed. Melinda, who owned quality for the ministry. We were golden. Now, we wouldn't had considered, and this was back in 2016, that there was this controversial conversation going around about the adoption of telemedicine. And our champions had done their external research from other organizations, and they confirmed, the reimbursement was going to be budget positive if they brought in our exam. What we never anticipated was that there was this larger conversation happening about billing codes for telemedicine at a national level in this organization. And we didn't know that Linda Gallows was considered the industry expert on corporate integrity and compliance for this health system. Not to mention, Linda had a national voice in the healthcare industry and on a national platform. We were a really young company. We were a startup. We didn't know to code her as red as a barrier until the day we'd sold it, onboarded the diagnostic, and were at go live, ready to see live patients. Linda got word of the implementation, and she called down to the medical officer stating that by no means would she support using that billing code outside of its traditional specialty setting. So we were dead in the water. Let me recover from my pain for a minute. Thank goodness that we've built a strong support system within the organization, because we were able to work with Linda and her team to create an alternate financial model of patient self-pay. But the opportunity never expanded to the levels we had built it towards. And I share this story to stress the importance of not taking stakeholders, their interests, their responsibilities for granted. Know your value, align your value, but then make certain you know how politics and other influences might play for you or against you. Selling into healthcare is complex. The strongest sales folks do their legwork before, throughout, and after closing the contract. Never assume you've got it in the bag, so to speak. Okay, so the previous slide showed a healthcare system that was a ministry market model of managing a healthcare system. Thereby, they make decisions at the local ministry level with some levels of autonomy. However, In that model, there are corporate entities and shared services like IT or compliance, we know about Linda, that may influence decision, right? Over the last several years, there's an old model emerging that started back in the early 1900s at Mayo Clinic called the dyad. And it's becoming, again, one of the most effective leadership models. The dyad model, and I'll talk to you about it, includes partnerships between physician leaders and administrative leaders. And then there's a triad model that extends the partnership to include nursing leadership. There was a study conducted in Q4 of 2019 by MGMA that found that almost 80% of health systems now operate in a dyad or even a triad model, and most groups say they wouldn't know how to effectively function without it. The dyad is a true partnership where operational, financial, and strategic decisions are made by the dyad partners, not independently and not in a vacuum. So why is this important selling into healthcare systems? Because if an organization is using the dyad model, you can bet that they have very solid decision-making skills and processes. In other words, know both sides of your value. Know positive and negative implications from a clinical view, as well as the operational implications, and be ready to speak to both and build relationships within the dyad structure. Don't think your champion is all you need. So let me give you an example of a dyad. I talked about St. Elizabeth's a little bit ago. I'll probably bring them up again because I am so impressed and have been for over a decade with this organization. Going back to our opportunity, telepodiatry solutions, let's look at St. Elizabeth's. This was not a public org chart that we went out and found. Instead, this is directly from their website, where their website shows clear relational ties of a well-defined dyad. Perhaps that's why they perform so high in quality attainment. So I went to their About Us portion of the website, and we're able to clearly map and associate all of the relationships. You can see in the blue lines where Dr. Pritchard is the lead physician while Jacob Bast leads operations. Together, they are the top dyad relationship. Each manages their teams, but each level of the team functions as a dyad partnership. So this means our partner, Dr. Michael Gieske, cannot make a decision without consulting his operational partner, Craig. Craig understands that while this might be a really attractive clinical solution, his team is going to have to operationalize everything, including figuring out if they need to contract with a home health network. There are so many complexities, and the dyad model helps to simplify these decisions within the organization. So I know that this sounds like it might cause you some delays, but this is a reality. So if you embrace it, and you know Dr. Gieske will get you a lunch with him and his partner, you might be able to mini pitch to Craig and learn some of your other weaknesses. So now you gain another champion on your own with Craig, and together they might just give your solution their recommendation. At times, depending on the size and the scale or any related capital, that recommendation might be all you need. They may have the decision-making ability, but if not, they are going to be the strongest voices of influence you can earn. So from this, a good question you can ask your champion, hey, does St. Elizabeth operate within a dyad structure? Who's your dyad partner, and how and when do we want to bring him into our conversation? That is a really, really strong start to networking your opportunity to higher levels up within the organization as needed. But then take this perspective. The reverse is true. Let's say my champion was Hank in clinical transformation. He's higher on the food chain, but he's going to rely on his dyad teams to appropriately vet anything he's going to endorse. In the dyad model, vendor relationships get left at the door. These dyad relationships are built on really strong trust and understanding, and they know together that any decisions they're making within are supporting the corporate and organizational missions of their organization. So it's really important not to overlook the dyad. Okay, so we know our value props, we've mapped our organization, we've determined any relationships that we still need to develop. Now let's look at these healthcare systems make decisions, these dyads. Whether in a dyad model, a triad, a ministry market, or something else, the system has its own internal processes. These may include product evaluations, committee approvals, or something else. We need to know their cycle to plan our sales strategies. And in an environment like COVID, maybe committee decisions are being waived and decisions are happening more quickly, but it's not the norm. Let's look at what is normal, and we can watch over time how we shift into that new version of normal. So The healthcare decision cycle. At Redox, we believe in solving the biggest problem in sight. In fact, it's in our DNA. The core value may be shared across healthcare. So the concept of everything is a priority, if everything's a priority, then nothing is a priority, that's really real. So health systems will solve their biggest pains first. But how do we help them take a problem, maybe something they've just learned to deal with, and make it the most important thing, their biggest problem in sight? How do we become a priority and create urgency? We recognize the healthcare decision cycle is a natural and formal process that all customers move through. They may move through stages quickly and they might not even realize it, but they do move through every stage of making buying decisions, and our goal should be to help guide them through. The decision cycle takes into account clinical, technical, and other criteria. It has a way of prioritizing the biggest problems and the biggest opportunities. There might be multiple stakeholders that may form decision-making teams, but as a salesperson, you should be able to measure where they are in their cycle by asking well-planned strategic questions. Knowing where they are will help you shorten the back end of your sales cycle, providing valuable information needed that may have your stakeholders stuck otherwise. You could be the one to unstick them. So, what it is not. It is very important to understand that as salespeople, we don't own this decision cycle. We influence it. The cycle is not our barrier, but rather it's a framework that cannot be ignored. And it should. The healthcare decision cycle is really valuable, and the best salespeople understand how to use it to develop relationships as trusted advisors in your area of expertise. So here's our healthcare decision cycle. We start with status quo. We've always just done it our best to manage foot disease when we find it. We've always just tried to better educate our patients. We've just learned to deal with it. So a good salesperson may ask, well, but if you could find foot disease earlier, what would that mean to your patients? If you could help patients monitor disease progression, do you think that would help with their compliance? Now we're having conversations that take the healthcare organization from status quo into problem recognition. You mean I could reduce amputations through technology? Oh, who'd have thunk? Okay, so we've asked probing questions that get our product higher visibility into their pains. Now we get to get prioritized. So if we're finding foot disease earlier, are there other complications you might catch or even help prevent with better patient compliance? What would that mean to your staff, to improving your costs? Are you on any shared risk contracts where you could reduce costs by improving outcomes? What would that look like for your practices? If we're having meaningful conversations with the buying team before they start to evaluate options, we are late to the game and we're likely to lose. If we ask if they have the problem and accept no or not really as the answer, we are missing the opportunity to guide their decision. If we open conversations by introducing our product, we miss the opportunity to learn how to shape the conversation. Keep your product in the bag until your stakeholders recognize it's a big enough problem to solve. So at this point, you become consultative. So later in solution evaluation, you can be prescriptive. The customer will start determining the criteria a solution would have to meet and create measures around the effectiveness of the solution in their mind. So they might say, okay, well, to solve this pain, the solution can't require heavy equipment for the home health nurse. It must absolutely have wireless connectivity and be easy to use. It must be low cost and budget positive, although I get it, it's not going to be a revenue generator. Might help keep our doors open. And it must provide the ability to diagnose and monitor diabetic foot disease. So by the time they are ready to look at your solution, you know their must-haves, their nice-to-haves, and their I don't really need that. So you can solve their problem and you've helped them get there. And if you don't, somebody else will. And it may take them down a completely different path. So let's talk. We have a good understanding of the natural process of buying decisions, especially in healthcare. But what does it mean to a salesperson? I have a sales cycle. I know my cycle. I know my average length of my sales cycle. But do I know where my customer is when I first approach them to begin my cycle? Let's look at how to overlay these two separate but complementary cycles to shorten the overall sales cycle. We're going to reduce bottlenecks and help customers get unstuck. right? So here we've got no need, no pain, no money, no time, no trust. If they're in status quo, it's where you want to start the conversation. Here you get to help identify the problem and shape the conversations. And it might feel like a longer cycle, but now you have influence. Probe to understand which of your value props resonate to start developing urgency. Leverage your champion to get to the person who owns each pain and empathize with them. Share their pain rather than cause their pain. Help them see it's a better way, it's a solution. Help them create specificity around the must-haves to solve their pain. Become a subject matter expert or a teacher or a coach, and then come back and confirm your understanding of their needs. So if I can provide you a solution that's portable, easy for nurses to use, doesn't require technical savvy, is an alternative to an office visit, and is at least budget neutral, would you be ready to solve this pain? Now you've evolved into the trusted advisor. You've listened more than you've presented. You've learned their processes, their pains, their frustrations, and their needs. You've helped them identify the need to solve a problem that otherwise they never knew they could solve. So you've really helped them find a better way. Recognizing where they are in their buying decisions helps you best position every conversation and learn what value is needed to advance their thinking. So let's get to the point where we all want to be, right? Let's get to the plan where we can ask for the business. First, we have to set our own criteria to determine when we've earned the right to ask for the business and what do we need. For St. Elizabeth's, it's a big health system. If I want to get the entire opportunity, I want a path to get there. I need to set singular sales objective. I've learned that they approach technology in pilots and in expansion phases. So I'm not going to try to change that. I'm not going to try to force that. My goal is to win a pilot of 4 clinics serving a high diabetic population. I've worked with my champion to define the clinics, and I've worked with the clinics to develop additional champions. I've also aligned the appropriate value propositions across that decision team. I already know there's a committee involved in the decision, found that out, and that committee meets to review products on the 3rd Wednesday of every month. I've created urgency in my team, and they were able to get us on the committee agenda for next month. So I've done all of this work around shaping and developing the opportunity for my customers. But wait a minute, so what about me, right? How do I plan my win? I need to ward off competition and make sure I can deliver what I've promised. So let's get to the point where we all want to be. Let's get to a plan where we ask for the business. The best salespeople I've ever known over the years have had a strategic plan always for their top 3 or 5 opportunities. And going through this exercise as part of sales planning helps them carry lessons to help with the smaller deals as well. So here we've got a tool that you can use. David's going to provide this after our sessions, but let's do a quick walkthrough. First, have your marketing team provide you with the top 5 or 6 customer pains that your solution solves. This is not your typical ideal customer criteria on size and scope. Instead, this is all about the characteristics of your customer that you are most able to solve, your quadruple aim value props. These are static across the top of the sheet until the market shifts and you need to update them. Next, let's create a measurable singular opportunity while also understanding the opportunity at scale. Our opportunity, St. Elizabeth's Physicians Pilot. The baseline opportunity is 4 clinics who manage 1,000 patients with diabetes collectively. The customer is in problem recognition in their decision stage, so I need to work with them on prioritization. I know they have 30 plus clinics and a diabetes center, but I also know that only about 15 of those clinics have viable populations. So I can set my long-term expansion goal and talk about my pilot as a proof of concept rather than a pilot. I know there's a committee involved, and I know when I'm on their docket. I can stay close to this to ensure I don't get bumped or reprioritized. I know my decision team, including the dyad teams of clinical transformation and primary care, and I've mapped whether they are champions or barriers that I have to overcome. I plot out their customer pains, their top 3, and I state my ability to solve it, as well as my competitors. So if you see on the tool, my ability to solve right next to competitors, because it is really important to keep them in mind and not take for granted your position, okay? From this, I can start building strength statements, my positioning to each area of decision-making. So do I have an advanced tactic where I can provide someone on my decision team a personal win when we look at, level of strength being relationship? Who's the right person on my team to deliver this? Maybe my VP of sales can make him or her look good in front of his peers. Or is the relationship a weakness where I haven't tried yet to understand how each person on the decision team may have a personal win if they select my product? Is this a gap? And does my competitor have the upper hand here? Is the deal stuck because they don't have technical information necessary for a security review? Do I even know if there's a security review involved? Does this happen before or after committee? And am I behind the eight ball? How do I get it moving? This is a technical advance. Or is my decision team struggling to understand the workflow that they're trying to implement? Do I know this? Have I talked about how to operationalize my solution? Do I have expertise on my team that can speak about workflow to help nudge the process forward? This would be a utility advance. My next best action would be to set up a meeting to discuss workflow. Now, not necessarily solve workflow, but to get the customer seeing that it's possible. We don't want to give away all of our secrets without a contract, right? So finally, there's a financial concern that I haven't addressed. If I were to return to my research grid, there are several unanswered questions around reimbursement. Can I have a conversation with my champion around this, or could he set it up with the right people? And have I armed my team of champions within the healthcare system with all the relevant information they need so they can present me to the committee? Or am I invited to the committee, or do I depend on them? So many questions. So now let me give you one last secret. I call this watergating. Take this very same tool and fill it out from the perspective of your competitor. What does he or she feel like their strengths are to beat you in your own deal? How would they position against you to win? What might they do as their next best actions to unseat you? It may change your approach. It might change your perspective. Guys, this is just one approach to strategic planning. There are so many tools and methodologies available out there. My recommendation is that you pick one that works for you and you adopt it. You operationalize it into your culture. Maybe it's this tool. Maybe you have a favorite tool. The idea is to be diligent with planning so you earn the right to win the business. Our healthcare industry depends on this from us. And I believe that that's why we're all together today, because we have products or technologies to solve pains and improve the outcomes. I've gone on for a long time. David, that's what I had to share. Are there any questions?
Wow. So first of all, Heidi, amazing job as expected, but the
thank you.
Feedback is super positive. Folks enjoyed it. For all those that asked, we are going to be distributing this video, the slides, and then you have the worksheets at the bottom. It's going to come in. We'll send it via email. It's going to be on our YouTube channel. Just stick with us and you'll get it all. Yeah, I've never hosted anything with Redox where we've had this much positive feedback. So Heidi, pat on your back. We got a couple questions.
Thank you.
I'm going to try to. We're running up against time, and I'm going to try to not eat up too much of Sarah's. So, but I do want to give you a chance because I think you have some wisdom to share here. There's two that are sort of top of funnel, and I'm going to try to bundle them. And that is, what are strategies for getting the prospect to take a call or email or engage in the discussion? Most are very difficult to reach. And then similarly, Jay asks, how do you find and locate the champions? So, and maybe those aren't as, now that I say them out loud, but if you can see that, and I got one more that I'd love to get to.
Yeah, great questions. I'll give you a real quick, simple answer. How do you get the prospect to take your call? And let me give it to you in an example. I had to do a lot of prospecting when I started in my old company. We didn't have a lot of inbound leads coming in from trade shows or anything. And I started researching different leadership efforts in my industry. And I did an outreach. I found that Providence Health and Services up in Washington had partnered with Walgreens. And I found the executive responsible for it. And I emailed him and I congratulated him. And I asked him about what he accomplished and why he did it. And I asked for a meeting. And I've seen a lot of people do it that way, where you just spend a little bit of time learning what's important to your prospect and asking and engaging them with that, rather than asking and engaging about, hey, do you want to talk about my product or my solution? That's one approach. There's quite a few, and we can certainly do a session on that.
Yeah, definitely. I know that.
What was the next one?
Yeah, so
go ahead.
How do you find and locate the champions?
So the key to finding the start, your foot in the door for the champion, is really in aligning that value prop, right? Understanding your position and what pain you can solve, and then learning in that organization who owns that pain. If you go back to the ministry example that I showed you, and our chief nursing officer within the ministry of the organization, she owned the quality measure, which means she gets her annual bonus based on achieving that quality measure. If you can find the person who is personally connected, the highest level in the organization that is personally connected to a win that you can bring them, you can engage them in the conversation the right way in your prospecting and your outbound reach to try to get just 5 minutes with them, and never ask for more than 20 minutes on your first call. Ask if they've got 15 or 20 minutes to talk.
Awesome. Okay, we got time for one more. Well, now shoot, they're just flowing in. Let me. Okay. Ooh, well, so we're just not going to have a time to get to all these. There's a good one about GPOs. Someone says, are they advisable for a smaller company? Do you have experience there? Is working via a reseller advisable?
So I have a very strong background in GPOs. Actually, I started my career back in 2000, selling what's called contract scrubbing on GPOs, and then doing trainings for years on them. From a technology standpoint, the GPO positioning is very difficult unless you have a piece of capital equipment that is a requirement to deliver your solution. But I think that that's a really big question, and one we could sure dive in on its own. If you have relationships with GPOs, certainly I would say distribution. If you have equipment that goes with your solution, you might, talk to some of the distributors as well. But it's hard to get in there. It's easier to start out by finding someone you know in healthcare and asking for introductions.